afternoon or good evening, wherever you are. Thank you for tuning in to the session today. So my name is Jason, I'm based in Melbourne in Australia. And the topic today, we'll be talking about urticaria in special populations. So let me introduce the faculty members today. We have a panel of esteemed speakers from different parts of the world, including Professor Dr. Petra Staubach-RenzUniversity from University Medical Center in Mainz in Germany, and Professor Dr. Kanokvalai KulthananSiriraj Hospital, Mahidol University in Bangkok in Thailand, and Professor Dr. Emek Kocatu from University School of Medicine in Istanbul, Turkiye, and also Charité Universitätsmedizin Berlin, Institute of Allergology, Fraunhofer, ITMP, Allergology and Immunology, IA, Berlin in Germany. So the learning objectives today include to understand the philosophy in treating urticaria in special populations and to apply current knowledge to urticaria management in special population. So Professor Staubach-RenzUniversity will talk about urticaria in children, and Professor Kulthanan will talk about urticaria in elderly and people with complex medical needs. And Professor Kocatu will talk about urticaria in pregnant and lactating women. The session is followed by Q&A for about 10 minutes. So feel free to send in your questions. So we have over 200 participants tonight, or this morning, from all over the world, covering all continents. From Europe to the African continent, South America, Australia, Asia, and North America. So this session is actually accredited for CME, but please remember to complete the feedback form at the end of the webinar in order to receive the points. And there is a survey at the end of this webinar. Please feel free to provide your feedback and take note of this QR code. If there's any questions, please feel free to leave your comments and questions in the Q box and the chat in the Zoom window. So without further ado, I think we should just, let me invite our first speaker, Professor Dr. Petra Staubach-RenzUniversity.
Can you see my screen? Yeah, fine. So hello, everyone. Nice welcome from Germany. Sunny weather here, and we have 12 o'clock lunchtime. Maybe it's different over the whole world. And I will talk about urticaria in children, some new things, some experienced things, and some unmet needs. That's what I'm going to share with you. I have some conflict of interest, of course. I'm doing the job treating patients about 25 years, overall inflammatory diseases, and we have a specialized out clinic for children with dermatological diseases. So urticaria, I think it's a common disease. It's not seldom. It's very often. It's common. Overall, the acute urticaria, and it's in every age and culture. And the same as in adults, we have hives, we have angioedema, sometimes together, and it's the same as in adults. Over at least every third has urticaria and angioedema from the talking about children. And the pruritus, that's the itching. This is the most important point why children, but also parents or siblings can't sleep. We have subtypes. Again, that's the same as in adults or adolescents. We have this acute less than 6 weeks, we have chronic urticaria, and there we have the spontaneous urticaria, the most often form, or the inducible, and we have combined forms. Here we have no numbers in children, how often it is combined in adults. We know every fourth have two subgroups of urticaria, and we think it's the same as in children. We have this inducible group where you can see here some numbers, how rare or how often it is. And we in Mainz, and I think that's differs a little bit of the regions, we see a lot of cold urticaria patients, small children, very small children. And in Berlin, for example, it's a little bit more in the north of Germany. They see more adults. We do not know why, but it seems to be a little bit different. We did a very big study, and it's published in GDDG, in 2021, where we looked for the subcohorts in a big group of patients with urticaria. It's insurance company paper, and we could see that every subtype of urticaria is diagnosed in children as well, and the same as in adults. And what we saw that if we look in this insurance numbers, more than 10 million of people are included. We could see that urticaria, but this includes acute as well, because we couldn't divide it. It's very often in smaller children and less often in the adolescents. That's what we know today. We have different types, that's some patient numbers, some patient pictures here, angioedema and pruritus and hives. And here we have, for example, cold urticaria. We are allowed to show those pictures. We ask always the parents and the children if we are allowed to show the pictures. And maybe, you know, we have some tests, for example, temp tests to measure the temperature where they react, or this Frick test for the dermatographism, or the solar urticaria. We can we can do a diagnostic with UVA or UVB light. We have an algorithm, maybe you know this algorithm of adults, and it's the same for in children. We know that we have sometimes only angioedema, and if they last longer than 2, 3, 4 days, we should think about HIE, even if they have a negative family anamnesis. We know that we have in 20% mutations, though it's possible that we have a new form of HIE. And overall, if we have the adolescents where the estrogens play an important role, and the first symptoms occur in this age, we should think about this not mast cell related or associated angioedema. But that's certain, but we have to take it in mind. If we have only wheals, and if we have patients, and this is really rare, and we see it in children as in adults, we have only sometimes symptoms, for example, 1 week in a month, and it's always in a combination of like a common cold, like with fatigue, with a bone joint or a pain, bone pain. Then we have to think about autoinflammatory, not autoimmune, but autoinflammatory diseases. And we know that this autoinflammatory syndromes, you do not need to know everyone, but very often we have rash or flares, and sometimes it looks like urticaria, and there we have to think with all those symptoms about autoinflammatory diseases. Here are some examples. This is seldom, but if this is only sometimes or recurrently, and they have systemic symptoms as well, you have to think about this in children as well. Otherwise, we are here, we are the chronic spontaneous inducible urticaria or the combined forms. And what's about causes and triggers? And I'm happy to share those data with all of you over the world, because this is really different all over the world, the triggers, the causes, and we think we know a little bit or some things about causes, but this is a picture of a girl, 8 years old, and she wrote, or she painted this picture with the bad and good guys in her gut, and maybe she knows something about microbiome and so on. And we did a study on this, but we have not results that we could recommend something to do with your gut, with taking microbiotics or something like this. But about pathophysiology, we know that as in adults that we think we have an autoallergy type 1 or an autoimmunity type 2b, a little bit against IgG antibodies against the receptor or the IgE. So it's the same as in the in adults, and the triggers, and that's different a little bit, and that's what we should explain our patients and the children as well. Triggers are, for example, drugs, infections, this antipyretic drugs which we take in children very often. We should use this because this may be a trigger. We should use paracetamol, but nothing else in children with urticaria. What's about comorbidities? We have a lot of comorbidities. Again, our study, we see more patients, more people with urticaria who have depression or anxiety, who have adipositas, so obesity, who have infections, or who have, for example, things around the atopic circle like rhinitis, like asthma, and so on. So it's more than in the population without urticaria. So there are comorbidities, and we should look for it and ask for it. And we know, and this is really interesting, that we have in children, again, the same as in adults, we have psychiatric disorders or anxiety disorders more often in CSU patients, small patients, than in controls. Who is managing the urticaria? And this is all interesting again, because we need to talk to those who are managing the urticaria in children. These are pediatricians, about 70% GPs, and the smallest number are seen with dermatologists. That's what we saw in Germany. Maybe it's different in other parts of the world. And again, our study, what it's about the treatment, and not surprising, they get antihistamines, second generation antihistamines, about every 3 of 10 patients, and antihistamines of the first generation, but also oral corticosteroids, what we should not use any longer. And sometimes, of course, antibiotics if it's combined, and that's very often in acute urticaria or in recurrent urticaria. Very often they take oral antibiotics because they have an infection as a trigger of the urticaria. Now coming to the guidelines, what do the international guidelines recommend? And we will have our guideline conference this year again in Berlin in December. And the guidelines suggest to do the same treatment algorithm, the same as in adults. We will talk about this now, and it's recommended to give the children second generation antihistamines, and if there is a need for updosing, we should updose it again, but it's important to take care for the children less than 6 years old, because if you have antihistamines which are metabolized over the gut or the liver, you shouldn't take, for example, desloratadine or loratadine, but you can take cetirizine or levocetirizine. That's the antihistamines which are recommended for children less than 6 years old. It's really important. And if you have to updose it, it's really important. And if it doesn't work with the updosing, you should use omalizumab as an add-on to the antihistamines, always weight adapted, of course. And omalizumab is licensed from the age of 12 years on. But as maybe some of you know, in asthma, for example, it's licensed from the age from 6 years on. So we use it very often off-label in the smaller children. We have children with 3 years who are treated with omalizumab, but again, it's off-label. And if that doesn't work, we can use cyclosporine, for example. And the problem is we should have disease control, of course, and that's what the guidelines say, but we have no validated scores. We have one validated score, that's a DLQI score for small children, for adolescents. We have this in different age groups. This is a German version with the pictures and so on, but we have no validated scores for children for the disease activity. And that's a pity, and we should work on this because this is important as well. If we look in children now in real life data, we did one study, and I mentioned before we have sometimes in children as in adults that we have no hives, but only angioedema. And if you think or you know it's mast cell mediator associated, then you can use, and we did this study in the past in adults, you can use omalizumab as well if antihistamines does not work. And I show you this picture, and the small boy allowed me to show the picture, but only if I'm showing the picture who is he's looking in normal world, in normal situations. And that's him, and it worked as it works in urticaria with or without hives. We did another study, the last slides now, where we looked daily life patients and real life data with CU or CSU, and we did some examinations, and here are the results, the improving UCT or the improvement of the UAS7 in children of all ages from week 0 to week 8. But we all know that we sometimes, and you can see it here, that sometimes it takes 12 or 16 weeks until they get the urticaria under control. So you should use it longer, even if it works not in the first days. Coming soon, this is relevant and important as well for children, because we learn to do studies in children as well. We know that we have a lot of drugs available for children, yes, but there was a hang. We have available treatment options, antihistamines. We have omalizumab as an anti-IgE. We have leukotriene antagonists. We do not need it any longer because it was not convincing the results, but we need other treatments and unmet needs now. My summary, overall, there are still a lot of data lacking in children. We have no specialized patient-reported outcomes, but also no disease activity validated scores. We need some more. Without those informations, no effective and efficient management is possible. We should work on those validated scores, and we are happy that we have new drugs who will hope be licensed this year or next year. We have, for example, remibrutinib as a BTK inhibitor, and there are phase 3 studies running in adolescents and planned studies in smaller children. And maybe you know dupilumab for license, for example, in atopic dermatitis up from the age of 6 months old babies. And here we are happy that the launch will come for CSU, for a subgroup of CSU, if they do not have a successful treatment with omalizumab. That's what's coming soon, and hopefully we will have as well coming soon a Your Child project in our UCARE family. And if you want to join it, please give me an email. There will be an advisory board this spring, and maybe we can work together. I would be happy to invite you to this. Thank you. And this is everyone out from my team. Thanks for listening.
Hello from Bangkok. My name is Kanokvalai Kunthanan. It's my great honor to share with you Urticaria in elderly and people with complex medical needs. My disclosure: as people are now living longer, leading to increase in the aging population worldwide, WHO defined elderly as the age of 60 years old or older, and the United Nations defined as the age of 65 years or older. And our current understanding of CU in elderly is still limited due to the limited number of the studies. And in the elderly, CSU can be associated with internal pathology, and polypharmacy due to the various comorbidity is common, and it can induce drug interaction. Moreover, in the elderly, changes in pharmacokinetics and pharmacodynamics should be kept in mind, and no specific recommendations regarding treatment of CU in older patients. The mainstay of treatment in the elderly consists of second-generation H1 antihistamine. Corticosteroid and cyclosporine should be used with caution. Alternative treatment options have not been systematically evaluated in elderly patients with CSU. I and the team have conducted a systematic review of chronic urticaria in elderly. Due to the relatively limited number of the study on CU in elderly, we include case report, case series, RCT, cohort, and other types of study of chronic urticaria in patients age equal to or greater than 60 years old, aiming to collect data from available published evidence as much as possible. 85 studies were included with more than 1 million elderly CU patients. Our limitations were most of the included articles were retrospective, case report, and case series, which were low level of evidence. Only 3 RCT were included, so the number of control groups was low, and a few studies have study population consist of elderly patients only. So the results should be interpreted with caution, but we would like to give some overview for the CU in elderly. The prevalence of elderly CU in general population range from 0.2% up to 2.8%. The prevalence of elderly CU among all CU patients range from 0.7 up to 33%. Focus on chronic spontaneous urticaria. 2 studies conducted in general population reported the percentage of elderly CSU among all CSU patients were 15% up to 32%, while study conducted in single center, the percentage of elderly among CSU patients ranged from 6.7% up to 22%. When we focus on chronic inducible urticaria, the percentage of elderly CSU patients was reported in only 5 studies. The highest proportion were described in general population, which was 16%. Women are predominant among elderly CSU, and CSU. The mean age at presentation reported among all CU patients was 70 years old. Most patients presented with wheal alone, followed by wheal with angioedema. AR, asthma, and AD were the common reported personal history of atopy. Elderly CU patients suffer from various age-related comorbidity. Unspecified GI disease were the most common reported concomitant disease. High reported rate of malignancy and autoimmune disease. Most malignancy were unspecified, but among those that were specified, GI cancer was the most prevalent. Severity of CU was reported in 19 studies, mostly moderate to severe disease activity. UAS7 was used in 13 studies, and the average score was 22. Laboratory result in elderly. Positive ASST was found in 48% of elderly CU. Basophil histamine release tests were reported in 6 studies, and the result was positive in 5 of 13 tested CU patients. Elevated serum IgE was reported in 42%, and elevated ESR in 27% of elderly CU. ANA was reported in 13 studies, with the average positivity of 16%. Anti-FcεR1 antibody was reported in only 1 study, positive in 2 out of 3 patients. No study reported abnormal free T3, but 13% of elderly CU patients had abnormal free T4. 18% have abnormal TSH. 24 studies reported thyroid autoantibodies with positivity rate of antithyroid peroxidase of 27% and antithyroglobulin antibody at 33%. When we compare the reported demographic and clinical characteristics of elderly patients with non-elderly CU, both groups mostly presented with wheal alone, but in the elderly were higher than in adult. CSU was the most common subtype among 2 groups. Symptomatic demographism was reported as the most common symptom in both groups. History of atopy was relatively low rate in elderly. Autoimmune disease reported in high rate in elderly, and high rate of malignancy in elderly. No difference in other laboratory findings. So in summary, compared to adult CU, elderly CU patients had a higher percentage of wheal alone and lower rate of positive autologous serum skin test and atopy. This is the algorithm for the treatment of CSU in older patients. The treatment in elderly follow the same treatment guideline as other population age. Second generation H1 antihistamine is the first line of treatment and can be up-dosed up to 4-fold. Avoiding to use the first generation antihistamine in the elderly as their side effects are more pronounced. If dose escalation cannot control symptoms, then additional medication may be required. This is the treatment and response among elderly CU, the result from our systematic review. You can see that second generation H1 antihistamine were commonly used, and the achievement of complete control was most often reported. Omalizumab was prescribed in 59 refractory patients, and a significant response to treatment was reported in most patients. The use of antihistamine and other medication to treat older patients with CU can be limited due to several factors, and in recalcitrant cases, other differential diagnosis related to underlying medical condition should be considered, and the treatment of comorbidities also yield significant improvement in chronic urticaria. This is the table showing real-world data on omalizumab in CIndU. Omalizumab is considered the second-line treatment, and a limited amount of real-life data is available, but appear to confirm its efficacy and safety in older patients. Only one study reported less response than non-elderly CSU. The use of antihistamine in elderly and patients with complex medical needs may be complicated by potential concerns of polypharmacy, comorbid disease, and organ insufficiency. Those adjustments may be required in patients with comorbid renal and liver insufficiency, so we should be aware of drug interaction as well. This is the list of second-generation H1 antihistamine and dose adjustment in patients with renal and hepatic function impairment. Cyclosporin is not licensed for CSU, and the drug has a risk of severe adverse effects, so its use in geriatric patients should be reserved to severe recalcitrant cases. The clearance of cyclosporin decreases with increasing age and older patients. Moreover, cyclosporin is a substrate of both CYP3A and P-glycoprotein, which are important in the elimination of many commonly used drugs, including antihistamines. 39 studies describe the treatment of secondary cause and the outcome of the treatment. For example, treatment of H. pylori, strongyloid infection, thyroid disease, the use of immunosuppressant and surgical removal for malignancy, and the treatment of secondary cause was also effective for controlling CU in elderly. Our systematic review revealed that when we compare the reported treatment of elderly with non-elderly CU, the regular dose of second-generation H1 antihistamine is generally sufficient to achieve complete control in most patients, with higher proportion of response in elderly CU than adult CU. And this is in line with the finding of lower rate of ASST in elderly. And as someone mentioned that ASST positivity correlate with higher disease severity and longer duration of disease in CSU. Geriatric patients may have less severe CU symptoms than adult CU, resulting in fewer associated angioedema and good response to standard treatment. Updosing of high dose or up to 4-fold second-generation H1 antihistamine was also reported with good efficacy. For patients who fail antihistamine, successful symptom control have been achieved with the use of omalizumab 150 mg up to 300 mg every 2 up to 4 weeks. So I would like to end with the key message that from our systematic review, the prevalence of CU ranged from 0.2 up to 2.8% in the elderly population. CSU was still the most common type and female predominance. Elderly CU was found to be different from adult CU in some clinical and lab aspects. Compared with adult CU, elderly CU has a lower rate of atrophy, angioedema, and ASST positivity, more age-related comorbidities. Non-sedating second-generation H1 antihistamine often yield good results. Omalizumab was effective in antihistamine-resistant cases. Treatment of secondary causes is important since elderly usually have age-related comorbidities. Other differential diagnoses related to underlying medical conditions should be considered in patients refractory to standard treatment. However, more prospective studies are necessary. And thank you for your attention.
So, hello, I'm Emek from Koç University, Istanbul, Turkey. I'm also a researcher in Charité University, Berlin. So it's my pleasure to be speaking about urticaria and angioedema in pregnancy and also lactation. So this topic really attracts my attention so much that we did a UCARE project on this and had nice information out of these projects. So I will share the results of our projects, and also I will give some information about what are the evidences we have on how to treat lactating and pregnant patients with chronic urticaria. So pregnancy is a special condition where the mother needs a degree of immunosuppression to tolerate the foreign fetus. But she also has to maintain sufficient immune function to fight off infections. So some specific immune adaptations occur that protect the mother from harmful pathogens, and also that allows for tolerance to fetal antigens. So let's have a look on what happens very basically. So in the early and late stages of pregnancy, we have a pro-inflammatory profile, immune profile, in which Th1 and Th17 cells inflammation dominates. During mid-gestation, a shift from Th1, Th17 to Th2 occurs. We also have higher levels, concentrations of T regulatory cells that suppress the maternal immune system and prevent fetal rejection. So basically, the first and third trimester is Th1 dominated immune milieu, while the second trimester is a Th2 dominated immune milieu. And what happens is asthma and atopic dermatitis tend to worsen at the second and third trimester, while during pregnancy, autoimmune diseases such as rheumatoid arthritis and multiple sclerosis tend to show improvement, while the mother, the pregnant woman, can experience propensity to infections like influenza or herpes. But what happens to chronic urticaria during pregnancy? We know very less about it. Even though we have a female dominant disease, we know that almost 70% of the chronic urticaria population is female, and they are in the reproductory cycle. So but we really know very less about, and urticaria is a common disease, so we really know very less about what happens to chronic urticaria patients during pregnancy and after pregnancy. What are the outcomes? So we wanted to learn more about it, and then we designed a UCARE project, which aimed to determine the changes in disease activity, treatment patterns, and outcomes in patients with chronic urticaria. So 21 centers, UCARE centers participated the study, the projects. So I would like to thank all my colleagues for their kind contributions and support. This was, of course, now 21 may seem very low, but it was just one of the first projects that were performed while the establishment of UCARE centers. It was a very early study. So what we found, we had almost 300 pregnant chronic urticaria patients data who had experienced pregnancy at the last 3 years. So we wanted to avoid bias with that. So in the general, in a global, the patients, half of the patients reported that their urticaria got better during pregnancy, while 1/3 reported that it got worse during pregnancy. And 10% of the patients needed emergency referrals because of their chronic urticaria exacerbations. And these exacerbations occurred mainly in the first and third trimester. In general, angioedema frequency lowered during pregnancy. So we can say that mainly urticaria tended to improve during pregnancy. And what happened to these improved patients is half of them worsened after delivery. So which patients tend to get worse during pregnancy? We wanted to understand this, and it was interesting that patients who had a milder disease before pregnancy tended to get worse during pregnancy, and patients with CIndU also tended to get worse during pregnancy. So the rates, but in general, the rates of emergency referrals and rate of angioedema during pregnancy were lower than non-pregnant chronic urticaria patients. So we hypothesized that our patient population comprised mostly of type 2B autoimmune CSU, given that all of them are females, and Th1, and it could be that their urticaria is driven by Th1, Th17 dominant inflammation that shows improvement during pregnancy, and vice versa, is that autoallergic patients might be the ones who showed deterioration during pregnancy. And the second study supported this idea that patients with higher total IgE levels got worse during pregnancy. The third publication from PregCU focused on the treatment patterns and also outcomes in patients with pregnancy and chronic urticaria. So we saw that most of the patients, over 80% of the patients, continued their chronic urticaria treatment, even though they decided to become pregnant. But after they learned that they are pregnant, then 28%, almost 1/3 of the patients stopped their treatment, and others changed their treatment. So there were, in the end, 60% of the patients who used treatments during pregnancy. And of course, the main treatment were antihistamines, and there were also users of first-generation antihistamines, which is 7.6, a higher percentage, and there were 16 patients who used omalizumab during pregnancy. So when we looked at the outcomes of pregnancy in patients with chronic urticaria, then the preterm birth rate and newborn medical problems rate were similar with the normal population. So chronic urticaria did not increase the worse outcomes did not lead to worse outcomes in patients. And it was also seen that preterm rates and newborns' medical problems were similar between patients who did and did not receive treatment during pregnancy. But when we checked who are the patients who had preterm birth, what were the risk factors for this, we found that emergency referral for chronic urticaria was a risk factor for preterm birth, and also having twins, which is already expected. But this is an important point that made us emphasize that keeping urticaria under control during pregnancy is very crucial to avoid worse outcomes of pregnancy. So now let's talk about treatment of chronic urticaria during pregnancy and lactation. As Petra already showed, we have the international guideline urticaria treatment guideline where we step up antihistamines. Then if not responsive, we use omalizumab treatment. And if omalizumab is not successful, then we switch to cyclosporin treatment. And the guideline also suggests to use the same treatment algorithm in pregnant and lactating patients, but of course with caution and after determining the risk benefit in these patients and discuss with the patients the potential outcomes of treatments. So let's go one by one. Which treatments do we have evidence or which information we have for guideline treatments? So there is a nice meta-analysis on the use of antihistamines during the first trimester. It included almost 50,000 women exposed to H1 antihistamines during the first trimester. And the conclusion is the use of H1 antihistamines during the first trimester is not associated with increased risk of major malformations or other worse pregnancy outcomes. So which antihistamines to use? The international guidelines suggest to use loratadine, desloratadine, cetirizine, and levocetirizine. And it also suggests to avoid first-generation H1 antihistamines during pregnancy. For the increased dosages of antihistamines during pregnancy, we don't have enough evidence. So the guideline also is a bit cautious about this. So it doesn't make a suggestion on the use of increased dose of antihistamines during pregnancy. So what about omalizumab? Omalizumab has been shown that it doesn't have any maternal toxicity, embryo toxicity, or teratogenicity in animal data, even in 12-fold the maximum clinical dose. And we also have a nice pregnancy registry, EXPECT, which has been performed in asthma patients. And in this study, 250 patients who were treated with omalizumab during pregnancy and were compared with the ones who did not use omalizumab but other conventional drugs. And when they compared the two cohorts, they showed that the results of pregnancy, the outcomes of pregnancy were similar between the patients who used omalizumab and did not use omalizumab during pregnancy. So from this study, they concluded that there was no evidence of an increased risk of major congenital anomalies following exposure to omalizumab. But of course, this is for asthma patients. We don't have a registry study for chronic urticaria patients, but we have many case reports, and also there is a recent Italian study where they shared the results of 29 chronic spontaneous urticaria patients where they used omalizumab during pregnancy, and the authors reported that there were no worse pregnancy outcomes in these patients. So I want to give very brief information about omalizumab use during pregnancy. In summary, the information of omalizumab use during pregnancy is limited, and we know that omalizumab has a very long life. It's 26 days, and if a female wants to become pregnant and wants to quit omalizumab, then they should be quitting omalizumab at least 4.5 months before conception due to its long half-life. This is one point. And the second point, if you want to, or the patient wants to continue omalizumab treatment during pregnancy, but is very scared about the worse outcomes of, or very anxious, then we can give omalizumab in the first trimester, because the greatest placenta transfer would be in the last trimester of a pregnancy. So first trimester would be safer to use. So with systemic steroids, short courses of use is safe. So we can use short courses of systemic steroids, and the choice should be prednisolone for systemic steroids. Very shortly we can use. Cyclosporin is category C. It's not teratogenic, but may be associated with premature delivery and low birth weight in infants. So hopefully not many patients need cyclosporin treatment during pregnancy because of their chronic urticaria. At least I didn't have any patients that needed cyclosporin during pregnancy. So antihistamines, and let's come to lactation. And during lactation, it's easier than pregnancy because the transfer rate of antihistamines is minimal, to the breast milk is minimal. Loratadine, cetirizine, and fexofenadine are the best studied ones. And also we can be relaxed with the use of, confident with the use of the antihistamines that we use during pregnancy. And higher doses seems to be safer during lactation because of the transfer rate is very low. And with omalizumab, it's because it's a very large protein molecule, the amount in milk is likely to be very low, and absorption in gastrointestinal tract of the babies is very unlikely. So it's compared to usage in pregnancy, it's safer to use in lactation. With systemic steroids, minimal amounts of prednisolone can be transferred to breast milk, so it's safer to wait for 4 hours before feeding the baby after ingestion of prednisolone. Cyclosporin, if we need to use cyclosporin during lactation, then the infants should be monitored, including measurement of serum cyclosporin and creatinine levels. So as take-home messages for pregnant and lactating chronic urticaria patients, first, it's important to keep the disease under control during pregnancy, and the guideline treatments appear safe to use during pregnancy. However, there is a lack of evidence-based safety information. Of course, we need prospective placebo-controlled studies in essence. And loratadine, desloratadine, and cetirizine and levocetirizine are the suggested antihistamines during pregnancy and lactation. No safety data about updosing antihistamines during pregnancy. Antihistamines transfer to breast milk is very low. Omalizumab seems like a safe option, especially in lactation and maybe for pregnancy. But for sure, the risks and benefits of every treatment should be discussed with the patient, and an informed and shared decision should be made. So the last message is keep urticaria under control during pregnancy. Thank you for your attention, and I'm ready to answer any questions.
Thank you very much to all our 3 speakers for the very educational and informative talks tonight. There are quite a number of questions coming in. So let's start with the first one. What is meant by allergic urticaria? Maybe we'll just get any of the speakers to help to dissect these questions. What is meant by allergic urticaria? Maybe we get Petra.
Yeah, I didn't get the question, sorry.
Yeah, one of the participants actually asked what is meant by allergic urticaria.
What is what? What is?
What is allergic urticaria?
Yeah, autoallergic, we think we know that in chronic urticaria we have sometimes autoallergic reaction, that we are reacting against ourselves. That's what we think about, that parts of our body we have an allergy, but it's not possible. We have not the possibility to look in labs at the moment for this, in normal labs, but we think there is a possibility in future. Allergic urticaria in acute urticaria is known sometimes, yeah, but only in acute, but not in chronic urticaria, or very, very seldom in chronic urticaria.
All right, thank you. I think there's also another question concerning your lecture. What is your experience with cyclosporine in children who did not respond to antihistamine or to Xolair, to omalizumab?
Yeah, very good question. I think we have to make sure, or to have to say that children is not children. If we have adolescent, the cyclosporine is licensed. It's not a problem. Even in pregnancy, as Emek told us, it's possible. And we have sometimes children in urticaria, but also in atopic dermatitis, who do not want to have an injection. For example, we had one child with suicide, who tried to do suicide because she had a very severe subform from urticaria, and there we took cyclosporine as a treatment option, even in smaller children, but not very, very often, not very common, because most of the time we can treat them with antihistamines and omalizumab. But of course, we need some more drugs.
All right, thank you.
The age less than 12, it's off-label.
All right, thank you. I think the next question is also for you. What do you think about omalizumab and cyclosporine in combination as
I saw the questions already. It's yes, it's possible. We did it, and we just published it, where we showed the combinations you could use and how safe they are, even in children. But we have only experience in adolescents, not in the smaller children, as a combination. But I think it could be. It could be possible.
All right. I think the next one is more of a comment rather than a question. Thank you for your lecture. I've seen many patients who suffer from anxiety and depression with urticaria, but find that effective treatment with omalizumab treat this effectively. I disagree with colleagues who treat empirically with sedating antihistamines such as hydroxyzine or doxepin for the antidepressant effect, since much of the psychological morbidity relates to the poor control of the urticaria.
Yes, I agree.
Yep.
I agree with Sasha. I want to say hi to him for his comment. Thank you. Because I just, we made a study on the depression scores to see how depression scores decreased after omalizumab treatment. And it was really profound effect on the depression scores after omalizumab treatment. And the ones who didn't respond mainly had more depression. So it's very important that we need to treat the comorbid psychiatric disorders. I really agree.
All right.
I agree too.
Yeah. The next question is related to parents are often concerned about the side effects of cyclosporine. How do you advise how to deal with the issue dealing with parents? Yeah.
I think it's again me. There is no advice. You have to discuss it with the parents, and again, it's only a second or third line therapeutic options. And if it's a short course, you can use it. You shouldn't use it for longer use. And it's a very old drug, so we shouldn't be afraid too much, but we have to monitor it in a really safe way.
Okay. And do you use D-dimer levels as surrogate for PRO in children?
No.
All right. What's your experience with the younger stage for omalizumab? Have you had experience with 3-year-old patients?
Yes, as I mentioned before, we have, and it's the same as in older children or in adults, and we have seen no side effects. Of course, it's an injection, and you should be experienced in doing this in children, but I think we learned in other diseases like atopic dermatitis, we are treating even 6 months old babies with biologics. So I think that's maybe the future, but I would recommend it to use it in smaller children as well. Yeah, but it's off-label. In urticaria, less than 12 years, it's off-label.
Okay. I think in the interest of time, it's not possible for us to address every question. I'll just skip to the next one. Probably I'll get Emek to answer this. Do you have data of use of bilastine and rupatadine in pregnancy and lactation?
Indeed, there are no prospective studies. I couldn't see any. And they are not considered as B category. I couldn't see any information about it. So I think it's better to stick with the most suggested ones. But bilastine is in its product cube, it's considered as B, pregnancy category B. But with rupatadine, it's always considered as C. So maybe bilastine, if the other suggested ones are not working, maybe bilastine, but rupatadine, maybe not.
All right.
I
Okay,
prefer to stick with the most evidence-based ones.
Okay. The next one is there any second generation antihistamine that we should not use? Or vice versa in elderly patients? Yeah, this is for Kanokvalai. Yeah.
Yes, I think that it depends on the patient's general health status, because some patients are healthy, but in some patients, especially in elderly, they have many underlying disease and many, for example, polypharmacy. So it depends. If the patient are very in good health, you can use any antihistamine. But if the patient have polypharmacy or many comorbidities, for example, liver and renal function disorder, you can have to be careful to select antihistamine. But I have already listed in the slide that the list of the second generation antihistamine that you have to reduce the dose, or you don't have to reduce the dose. The safe one should be bilastine, which you can use in the patient with renal or hepatic impairment. But other antihistamine, you can use it. It depends on the underlying disease of the patient as well. So thank you.
Right, thanks. And what do you think of omalizumab in the treatment of CSU accompanied by malignancy? Actually,
I think you can use it in the patient with malignancy, but this is we have to study further. But according to mechanism of action or something like that, and case report, you can use omalizumab in malignancy, but you have to wait about the risk and benefit as well.
Right. Would tacrolimus work in chronic urticaria?
I think in US there are experience in using tacrolimus in chronic urticaria, as I remember from their reviews and alternative treatments papers. But I don't really have any experience on using tacrolimus in CSU. Does anybody have? But it should work.
Okay.
But much more expensive.
Yeah. All right. Is Hashimoto thyroiditis?
There is a question to me, Jason. What will be your treatment choice in omalizumab resistant?
Omalizumab resistant in pregnant patients.
That's a difficult question, and I hope we don't encounter these patients. But I would go with the guidelines. So I would use cyclosporin if this is a really very resistant patient. Cyclosporin has been used many transplant pregnant patients, so it's not that bad to use from my point of view. It doesn't cause any malformations, but only small gestational birth. So I would go with cyclosporin.
Okay.
Maybe with low doses.
Yeah. I think there's one question. Some patients claim the urticaria get worse right after food intake, no matter what food after each meal. What does it mean?
So it can be maybe associated with a parasympathetic response increase, because I know Murat Türk and his colleagues made a study that showed that freak test results were increasing after food intake, whatever you take. I think this is a physiological response that may increase body's allergic responses, I guess,
Yeah.
but it's not a specific thing, I believe. It's physiological parasympathetic response, maybe vasodilatation.
And also, I think last year there was a paper regarding symptomatic demographism, which can be food exacerbated or food dependent. I think that was published last year as well. Yeah. All right. One question, what is the value of adding montelukast to 4-fold antihistamine in pediatric cases?
Did Petra leave?
Yeah, Petra. Yeah.
I think it's only you and me, Jason, now.
Oh, all right. Okay.
Maybe we can
All
conclude.
right. Maybe we close the sessions. Yeah. So thank you, everyone. So please complete the feedback form using the QR code to receive the CMB point. And let me take this opportunity to announce upcoming ACARE Level Up sessions on the 14th of May. And also on the 25th of June. And obviously, with UCARE Level Up, All Things Urticaria podcast, please feel free to participate. And there's also a lot of scientific projects that you can look into, organized by the UCARE committee. And there are quite a few international meetings coming up in December and Copenhagen, as well as in Berlin. And not forgetting the fact that there's a lot of information that you can read about regarding UCARE in UCARE Level Up newsletter. That way you can keep yourself up to date with all the latest news. So with that, thank you so much.
Thank you so much. To participants from all over the world, thanks for listening to us.
Yeah, have a good
Hope
day,
you
everyone.
find it useful.
Yes.
Bye-bye. Bye, Jason.